My name is Professor Ndubeze Okonkwo. I am a biochemist, internal medicine specialist, a consultant in nephrology, which is kidney and hypertension, and I did an ultra subspecialty in solid organ transplantation medicine, consulting in kidneys and pancreas transplant. This is a quick video on erectile dysfunction. And the reason I'm doing this are twofold. One is certain level of misconception that Viagra is for every person and cures all erectile dysfunction. And the other is the assumption that sexuality does not change as we progress in age. So when one is aging because of certain medical problems and certain physiologic changes, the performance of a 65 years old, a 70 years old, and 80 years old is not the same as that of a 20-year-old. So for something that ought to give you pleasure, shouldn't be a source of death. So if someone is urging you to go for it, when you know your body is not going to support what you're being asked to do, you need to save your life. Using evidence-based medicine, it should be very clear to us why there are differences in different age groups and why one can still maintain good sexual health. You don't need to kill yourself in the process. Erectile dysfunction can affect anyone, can affect anybody of any age. And so understanding the physiology of it or the science of it makes it easier for one to figure out what's going on with him or her, and then direct your intervention to the cause of your problem, because it's not one shoe fit all or one size fit all. Erectile dysfunction for men can be challenging. However, most of them can be solved. The most common cause of erectile dysfunction in men is psychogenic, sometimes called performance anxiety. As we all know, sexual arousal comes from multiple sources. Sight, by looking at someone, it can trigger sexual arousal. Smell can do the same. Touch, which is tactile arousal, somebody can touch you in a particular way and then you arouse. So there are other things that can cause someone to be aroused sexually. And so there is a reason why they happen, because for one to have a good sexual arousal, a good sexual performance, it has a lot of systems in your body interconnected to make it possible. So if one system is dysfunctional, it's going to affect the rest of the systems. So the summary of the science of it, so before we get to the pathology and then the treatment, is that when someone looks at a naked woman, okay, something happens to your brain, and that particular brain, without you knowing it, sends information to your spinal cord, which tells you that your brain and your spinal cord are both participants in the process of sexual activity. So that information that is sent from the brain to the spinal cord, it will go to an area of the spinal cord we call S2 to S4, the sacral area. You don't need to memorize them. Just know that there's a portion of your spinal cord that is called sacral region, and there's an area that is S2 to S4 as we map them. There are neurons there, which is the seat of nerves, or you can say nerve cells, if we can use that term. So that information coming to the brain goes to the S2 to S4 neurons, and sends an information to it, then that quickly triggers that neuron to send out information through the nerve fiber, which is like an electric wire, and it will go straight from the spinal cord straight to the penis. And for anyone who has a penis, you will know that the penis, if it's erect, it's like a rod. It's just straightforward. Then inside the penis is like a tube or a hole called the urethra, from where a man urinates. It is through the same urethra that somebody is going to ejaculate to produce the sperm to come outside. And so we call this process that of this initial stimulation is a parasympathetic action. And one of the ways to remember this parasympathetic action is if you eat food and then you sit around to watch TV for 2 minutes, you fall asleep. Whereas if you're hungry, you won't fall asleep. Okay, so this is a parasympathetic chain that triggered this event and make it happen. That is to get the arousal, okay, which is the stimulation, right? And then the ejaculation part is dealt with by the sympathetic chain, and I'm going to get to that in a second. So when one looks at a woman who is naked, what happens is that something in your brain triggers off, sends information to S2, S3 of your to S4 of your spinal cord, and the wire from the neuron or the nerve center or nerve cell will send out a signal through the wire, and the signal is going to travel. And when it gets to the end, it will release a chemical called acetylcholine. You don't need to remember the name. Just remember that there's a chemical that is released there when it gets to the penis. Okay, when the acetylcholine is released, it's going to do something to the tissue of the penis. Okay, and that goes through a nerve we call pelvic nerve. They don't need to remember this. Just know that there is an information that goes from the brain to the spinal cord, and that information gets to the penis, and then the tissue of the penis, the spongy tissue of the penis, is what determines erection. So that tissue is soft until you have a large engorgement of blood flowing into the arteries of the penis, making the tissue expand. And when it expands, any blood that travels somewhere must return. So for this to return, it's going to return from the veins back into the circulation, and then the penis will collapse back to its soft status. But once you have erection, you won't have any venous return in a sense, because the hard tissue is going to block the vein from draining any blood out of the penis, and that's how you maintain the erection. And so there is a mechanism. All I can say in a summary is that when the penis spongy tissue receives this signal, it goes through a process in which that acetylcholine does something to the tissue, and then there is an amino acid that comes from the food you eat. It's called arginine. That arginine is broken into two parts by a certain enzyme. Don't worry about what the enzyme is called, to produce nitric oxide, and then another component is acetylcholine. It is the nitric oxide is the one that we're concerned about. That is our friend. What it's going to do is it's going to dilate the arteries in your penis to be wide open so that blood can rush into it. When the blood rushes into these arteries, okay, the penis gets stiff. But as the blood is rushing in, it's making because the tissue, the soft tissue called this, I won't bother with the name, cavernosa spongiosa. It's a name, just the soft tissue of the penis is going to expand. And as it's expanding, the blood vessel is getting engorged because they are wide open with blood coming in. And so the penis gets stiff. If the blood drains out of the penis, then the penis collapses. So if you want to have erection for 200 years, and as long as this nitric oxide is there, and the soft tissue is expanded, and the blood vessel is engorged with blood and doesn't return, it's going to be there forever. And of course, you're either going to have a problem called priapism because it has to be drained out eventually. But this is how you get erection. If you interrupt any of these processes in the brain, in the spinal cord, or the nerve bringing it to the penis, and the nitric oxide production, and nitric oxide sustenance, and dilatation of the blood vessel, then you have erectile dysfunction. So if you interrupt any of these processes, you have a problem. So when there's erectile dysfunction, our goal is to go and find out where is the problem. Number two is that even if I have erection, then at a point one has to have an orgasm. And then if you have orgasm, you're going to ejaculate. And when you ejaculate, you're going to ejaculate semen. And this semen you ejaculate is made up of sperm and seminal fluid. The sperm is produced by the testis, the testicle, and then it's stored in epididymis, which is another structure there. And then seminal fluid is made, and it's stored in seminal vesicles. So when one ejaculates, these two things combine together, seminal fluid and the sperm, will form semen. Before they exit, something is going to happen to push it out. And this is a sympathetic activity, which is different from the parasympathetic I just described. So you can have erection and have sex because the parasympathetic activities are working well. If the sympathetic one is not working well, you can have all the sex in this world, but you're not going to ejaculate. If the testis doesn't make the sperm, it can ejaculate the seminal fluid, but you don't have sperm in it. So at any point you interrupt any of the processes, there's a problem. So this is the basic summary of the science of having erection and having sexual activity and then ejaculating. When the person is done and the brain knows, hey, this person is going to die unless I make him stop, something is going to happen in your brain which is going to send another signal to your spinal cord, but this time it's going to a different location, and that location is going to be going to a different one between T12 and L2, okay? And that's going to send a sympathetic signal back to the penis, and when it goes there, something is going to happen. That nitric oxide that you produce, for you to have adequate erection, is going to signal the breakdown of something we call a GTP to give you a GMP. That GMP is what maintains the dilatation. If you kill the GMP, the dilatation goes down and the penis collapses. So when it's time, your body tells you that you need to stop by sending a sympathetic signal to your penis area. And when it gets there, it's going to release an enzyme called phosphodiesterase 5. When it goes there, it's going to inhibit. It's going to inhibit or degrade. It's going to break down that GMP. If you break down the GMP, then dilatation stops and then penis collapses. But if you can sustain the GMP forever, then erection continues. So when the phosphodiesterase comes and breaks down the GMP, erection goes down. Before it goes down, the ejaculation process takes place and the sperm is ejaculated. What Viagra does is it comes to this phosphodiesterase process and it will block it, so that the effect of phosphodiesterase on the GMP will it's not going to take place. So your GMP continues to be high, therefore erection continues. But if I give this person Viagra, but his problem is in his brain, it's not going to help him because the Viagra works at the level of the penis. It's not at the level of the brain, it's not at the level of the spinal cord, it's not at the level of any other place. And there are many places that are involved. This is just a summary. Therefore, one needs to know Viagra is not an answer for all erectile dysfunction, because you may be wasting your money for nothing or kill yourself in the process, because not everybody can take Viagra. If you have heart disease, have to be careful. You can't start Viagra until you speak to your physician to make sure you don't have coronary artery disease, because of severe vasodilatation can cause you to have a heart attack and you can die. Okay? So having said that, so if we see someone with erectile dysfunction, the approach is to find out, is this psychogenic or is this medical, or is this mechanical? Is this psychogenic, anxiety and stuff like that? Okay? If it's not anxiety, which is majority of the cases, is psychogenic. Of the ones that are not psychogenic, they are equally many when they divided into different classifications. So if you have hypogonadism, remember that is the testis that produces sperm that induces, and testosterone is the hormone you need to have erection. Apart from making sperm, that testosterone, if it's not produced in an adequate amount, you're not going to be able to have an erection. So if the problem is testosterone, then you give the person testosterone by either injection or by pill. And then the person can have adequate level of testosterone and then can have erection. You don't need Viagra. So hypogonadism is dealing with the gonads. If the level of hormones produced are low, if you correct the level of the hormone, the problem is solved. Other times it can be a problem with the thyroid hormone, the thyroid gland here. If the person has hypothyroidism, if you correct it, erectile dysfunction disappears. Or somebody may be secreting the same milk that a woman has, called prolactin, because we, as men, we can produce the same hormones that women produce. If you have a FSH, follicular stimulating hormone, and luteinizing hormone, they are produced in the brain. And so if the area where they are produced is affected, it's not going to stimulate your gonads to produce enough testosterone. So then you have to go and correct the problem in the brain and not in the penis. And then if it's not hypogonadism, then you think about the blood vessel. Is it open enough for blood to come into the penis? One of the ways you can study that is when somebody who has peripheral arterial disease, meaning if you have plaques or formation of cement-like structures inside your blood vessel causing the lumen to be small, enough blood won't go through. So if somebody has problem with the aorta and the iliac trunk, aorta is the big blood vessel that brings blood from the heart. The iliac trunk is the one that you will have many branches that eventually some will be going to your penis. So if you have sclerosis in that area or blockade in that area, it's going to eventually affect the penis. And then even if you take Viagra for now till eternity, you won't have enough blood flow to get there. Therefore, if you don't get enough blood coming into the spongy tissue of the penis does not get enlarged, and therefore you can get stiff. So what are the causes of peripheral arterial disease or peripheral vascular disease? It's usually things we can control: hypertension, diabetes, high cholesterol, among many other things, but these are major ones. Smoking. So if you don't want this problem to happen, or if you're having this problem, these are things you need to look at to see if it's affecting you. If you're smoking, then you need to stop smoking. If it's drinking, you need to stop drinking, because both affect ability to have erection. And then is one's problems neurogenic? Is it coming from the nerves? Because if you have a stroke affecting your brain, or if you have a problem with the nerves coming out of the spinal cord or along the path going to the penis, something is abnormal. There's the chemicals that you need that's going to send the stimulus or the message isn't going to go through. So somebody who has diabetes has the nerves damaged or have blood vessels damaged. Two of them combined together makes it difficult for somebody with diabetes over a long period of time to be able to maintain erection. So that's another cause of it. Neurogenic component can come from medications. You're taking medication for something else. It can cause you to have erectile dysfunction. And one of the ways you can determine whether this is psychogenic or whether this is medical, you do a study at night with the patient to see whether their penis gets up, gets stiff when they're sleeping. If the penis can get stiff when they're sleeping, then it means it can get stiff by itself. Therefore, there's no obstruction. So So the chance that this is psychogenic is high. And then we go quickly to the treatment. So the treatment is directed at the problem. So if you have a reversible cause, if you have a problem that is reversible, then you go straight to the problem. If it's in the brain, the hormones are low, you replace the hormone. If it's in the gonad and the hormones are low, you replace the hormones. So if the problem is in the penis, because the blood vessel is not dilating as a result of, say, something like diabetes, there are other things you can do. But in that particular case, if the problem is you have dilation but it's not significant enough, Viagra may help. So if Viagra doesn't help, the next treatment to try, as I said, is going to be a PEG1 agonist. It's a kind of medication that increases what we call a cyclic AMP. That increases vasodilatation, making blood to stay put. As much blood will rush in, and that, as I explained before, will make the spongy tissue of the penis to get bigger and bigger, and by its expansion will constrict the veins so they don't drain blood out of the penis. And that's how that one works. And this one is actually injected into the penis. It can be a minor pain, but maybe the pleasure was the pain, but it works in some people. Another treatment is to use a vacuum device, in which you put the penis into a vacuum device, and the vacuum creates ability to draw the blood into the arteries, giving the penis the opportunity to be stiff. And finally, if that doesn't work, final approach is the surgeons can put in a prosthetic device which has a bulb, and you can inject saline, like salt water, into that bulb, which engorges the penis, and then drains out at the end of the sexual activity. And there are other implants. There is one they can implant that doesn't have to use saline. It's like a plastic device, if I may use the expression plastic, that keeps the penis stiff round the clock. It doesn't hurt. And some of my patients, particularly those with end-stage renal disease, as you know, who have diabetes and hypertension, as well as atherosclerosis, as major problems precipitating erectile dysfunction. And of course, at the end of the day, modification of factors that can lead to erectile dysfunction is part of the treatment, one of which is weight reduction. Overweight causes, or is associated with erectile dysfunction, because overweight causes a whole lot of problems other than erectile dysfunction. Again, smoking, cigarette, and alcohol consumption both affect erectile dysfunction. And even if you don't have it yet, it's prudent for you to cut down on this, because they cause other health problems, including the erectile dysfunction. Thank you for listening, and I hope it helps you.